Okay, let's dive into this. Here's our exact roadmap for today. We'll start with the splenic injury classification, followed by management and hemodynamic status. Then we'll hit key clinical pearls, classic exam traps, and finish up with a quick recall knowledge check.
First up, we're tackling the AAST splenic injury classification.
And this brilliantly illustrates the whole picture. Think of the AAST organ injury scale as basically the universal language for trauma surgeons. When a trauma scan comes back, everyone in the room needs to know exactly what a specific grade means. The system runs from 1 to 5. We move progressively from minor localized trauma, like small capsular tears in grade 1, all the way down to grade V, which is a completely shattered spleen. Grades I, 2, and 3 focus largely on the size of the hematomas and laceration depth, while grades 4 and 5 shift entirely to major vascular involvement. Let's break down the exact thresholds.
All right, starting with grade 1. For the exam, you really just need to lock in two specific numbers. The subcapsular hematoma involves strictly less than 10% of the surface area, or if you're evaluating a capsular laceration, it's less than 1 centimeter in depth. Very superficial, very localized.
Let's move to grade 2 and see how this builds. We're stepping it up a notch. That subcapsular hematoma now covers between 10 and 50% of the surface area. Intraparenchymal hematomas are under 5 centimeters, and lacerations are 1 to 3 centimeters deep. But crucially, there is no trabecular vessel involvement yet.
Now, grade 3 is where we see a significant leap in severity. The subcapsular hematoma completely exceeds 50% of the surface area, or it's actively expanding. You might see a ruptured subcapsular or intraparenchymal hematoma, and the intraparenchymal hematoma itself is 5 centimeters or larger. And the laceration? It's deeper than 3 centimeters or, and this is key, it's finally involving those trabecular vessels.
Which brings us to the critical vascular distinctions between grade 4 and grade 5. Grade 4 involves injury to the segmental or hilar vessels, producing greater than 25% devascularization of the spleen. Remember that threshold, greater than 25%. Grade 5 is the absolute extreme. This is your completely shattered spleen or a hilar vascular injury causing complete devascularization. Literally no blood supply left.
Moving on to section 2, management and hemodynamic status. Okay, put on your senior attending hat for a second. So the crucial point is, grading is really only half the battle. The patient's clinical status is what actually dictates your actions. This is your absolute fork in the road. If your patient is hemodynamically stable, you're generally heading down a non-operative pathway. But if they're unstable, you don't delay. It demands immediate hemorrhage control with an urgent laparotomy to save their life.
Let's map out that non-operative management or NOM pathway for the stable patient. Step 1 is close monitoring with serial clinical exams. Step 2, serial hemoglobins, just to make sure they aren't slowly bleeding out on you. Step 3 is a contrast-enhanced CT. You can actually consider this even for high-grade injuries if the patient remains perfectly suitable and stable. And finally, Step 4, angioembolization. This is absolutely your go-to move if the scan shows active arterial bleeding, like a contrast blush or a pseudoaneurysm.
Next up, key clinical pearls. Let's dig into the why behind all this.
I literally cannot reinforce this dichotomy of care enough. Hemodynamic status dictates management. Stable equals consider non-operative management. Unstable equals urgent operative hemorrhage control. But why exactly do we push so hard for non-operative management when we can? Well, it's because splenic preservation is incredibly important. The spleen isn't just an organ that bleeds. It has vital immunological functions.
Specifically, the spleen is our primary defense against encapsulated organisms. So if you do have to perform a splenectomy, you absolutely must vaccinate the patient. This right here is a guaranteed exam target. You've got to know these 3 bugs cold: Streptococcus pneumoniae, Neisseria meningitis, and Haemophilus influenza type B. Without a spleen, a patient is highly vulnerable to devastating sepsis from these specific bacteria. Don't forget them.
All right, section 4, classic exam traps. Let's make sure you don't fall for these pitfalls.
Now, what's really interesting about this slide is it debunks the biggest myth in trauma surgery revision. Trap number 1, a grade 5 injury does not automatically equal an immediate splenectomy. In an experienced trauma center, a completely hemodynamically stable patient with a high-grade injury might actually be managed non-operatively. Never, ever let a high-grade force you into surgery if the question stem screams that the patient is perfectly stable.
And that leads perfectly right into trap number 2. The AAST grade alone doesn't determine the treatment. Examiners love to put a low-grade injury, like a grade 2, inside an unstable patient whose blood pressure is tanking. That patient needs an urgent laparotomy. Contrast that with a grade 5 shattered spleen in a patient with perfectly normal, stable vitals. The grade 2 patient is actually vastly more urgent. Treat the patient, guys, not just the scan.
Trap number 3 is honestly just a simple vocabulary mix-up. Do not confuse your vascular thresholds on multiple choice questions. If the devascularization is greater than 25%, but it's not total, it's a grade 4. If it specifically says shattered spleen or complete hilar devascularization, boom, that is your grade 5. Keep those definitions strictly separated in your head and you'll be golden.
Finally, Section 5. Let's do a quick recall knowledge check.
Listen closely to this clinical scenario. A hemodynamically stable patient has a splenic injury with a segmental vascular injury causing 30% devascularization. I'll give you a second to think. What is the ASAT's grade?
Got it? The answer is grade 4. Because that segmental injury caused devascularization greater than the 25% threshold, but it's not a completely devascularized or shattered spleen, it lands perfectly in the grade 4 category. Fantastic job if you caught that one.
To wrap up today's explainer, I want to leave you with a little provocative thought. Will relying on hemodynamic status, rather than just staring at the terrifying grade on the CT report, fundamentally change how you triage your next trauma patient on the wards? Remember, the best surgeons don't just blindly memorize scales. They synthesize the imaging with a living, breathing patient right in front of them. Keep this framework in your back pocket, trust your clinical exams, and you're going to absolutely crush your surgical boards. Thanks for hanging out with me, and keep learning.